I'd like to introduce Dr. Scott Friedman, who's going to be presenting today, Brief Psychodynamic Therapy, a Relational Approach. Dr. Friedman received his Doctor of Psychology in Clinical Psychology from Hahnemann University in Philadelphia in Pennsylvania, 1983. Dr. Friedman is a licensed psychologist in the state of Georgia. He has earned a diplomate in clinical psychology from the American Board of Professional Psychology and is also a fellow of the American Academy of Clinical Psychology and a member of the American Psychological Association. Dr. Friedman is currently the practicum course lead for Yorkville University's Master of Arts in Counseling Psychology program. Dr. Friedman has worked in group practices providing individual psychotherapy, psychological testing, couples and family therapy. Dr. Friedman has also served as vice chairperson of the board of a nonprofit organization dedicated to child sexual abuse prevention and education. Dr. Friedman has also lectured on the role of mental health professionals in child sexual abuse treatment, prevention, and education. Dr. Friedman, we're looking forward to hearing your presentation. And everyone, please type your questions into the Q&A. There's a space called Q&A. Please type your questions because Dr. Friedman will have some time near the end today to answer questions. Thanks. Dr. Friedman.
Thank you very much, Dr. Zeman, for the introduction. It's really a pleasure to have a valued colleague as the host. And so I'm going to be talking about brief psychodynamic therapy, a relational approach, and follow up on a brief conversation that you and I just had, Don, that people think that psychodynamic therapy has to be long-term. And there are many models of brief psychodynamic therapy. And when I say brief, I'm talking about 12 to 18 to 24 sessions. So let me talk a little bit about this, and eventually I'm going to give a case example as well. So there are a lot of different models of brief psychodynamic psychotherapy. Some of the ones not listed here really fall within what we would call more of the drive or structural model that would be really similar to the classical Freudian approach. And then in terms of relational models, Marty Horowitz has a method called person schemas and problematic script sequences. Weiss and Sampson discuss pathogenic beliefs. Strupp and Binder talk about the cyclical maladaptive pattern. And Lester Luborsky, who I'm going to be talking about, developed with colleagues the Core Conflictual Relationship Theme model. And so there are a number of relational or interpersonal models that really look at the problems, the symptoms, the maladaptive relationship patterns that clients have as very, very related to interpersonal, to transference and interpersonal learning and maladaptive patterns that are repeated throughout a person's life. And you'll notice when I talk about psychodynamic therapy, there are going to be some overlap with some cognitive behavioral therapy perspectives and points of view. So I wanted to give you a sense of these different relational models that are there that may interest you. They all tend to have some very common factors when we talk about psychodynamic relational models. What we are looking at are the maladaptive relationship styles and patterns. What are the patterns that people repeat over and over again in terms of their lives? Psychodynamic models look at adult problems as the residue of childhood experiences that still kind of are in some ways a freeze frame in the brain, and we take into our adult relationships. It's interesting when clients come in, and some of them come to see me because of my orientation, some not. a number of people say, well, I really don't want to talk much about the past. I've resolved a lot of that. I really want to talk about my current life and relationships. And I discuss with them that we don't have to only do archaeology where we're going to figure out all aspects of your early life, but that the past is in the present. It's alive in how you relate to people in your life, and it's going to be alive in some ways in how you and I relate to one another. Psychodynamic models look at the unconscious as a motivating force, that there are things that are certainly not in our awareness, and certainly cognitive behavioral people talk about the non-conscious forces or schemas. And here's a very important aspect of all psychodynamic relational models, the transference template. And you're all familiar to some different degrees with transference. And certainly transference has both cognitive as well as affective or emotional components. And in a book called Understanding Transference, Dr. Luborsky and Dr. Christoph and I and colleagues have written about the transference template and research on its use in psychodynamic psychotherapy. And I'll give you a very quick transference template example. Many years ago, I was at teaching for a university, and I was at a residency, and we were sitting there, a lot of faculty where students were coming to show us their dissertation. And a student who knew me and saw me as a friendly enough person came up to me and said, you know, I'd really like to show Dr. X, another faculty member, my dissertation, but I really am concerned that they're going to be critical and really disappointed in the work that I'm doing. And I asked, well, do you really know Dr. X, and have you had any kind of interaction or relationship with them? No, but I just have this feeling that that's the way that they may look at it. So I didn't say to them, well, thanks a lot for not being interested in my point of view. What I saw was they saw me as a friendly enough person, and I needed in some way to reassure them that this was kind of a little premature and maybe in their head, that they were seeing this other faculty member as going to be critical and disappointed with them. And we can see that transference occurs not only in psychotherapy, but in everyday situations. And certainly social psychologists have talked about attribution theory. So these are some of the common relational factors that are critical in our work with clients. Some common relational factors, I mentioned that the past is present in the here and now in our relationship patterns, including sometimes with the therapist. So many years ago, I saw a young woman, a college student in a college mental health setting, who I saw for a couple of sessions, and she grew up where there was early loss, emotional neglect. And she comes to the session, and I'm sitting in there waiting for her, and she walks in and says, oh, I thought you had given my session away. And I said, oh, how so? Well, I got into the elevator, and I was about to press 7, because the counseling center is on the 7th floor. Somebody else got in and pressed 7, and I thought, wow, Dr. Friedman, forgot about me, and he's given my time to someone else. I'm not the only person on the 7th floor, and we've had only limited interaction, and you can see how that transference template was activated in the elevator for her, where for other people, they may have just thought, oh, good, somebody pressed the 7th floor. So when there is transference, it tends to be activated by a particular scenario or situation. Another common factor is the therapist offers what we call a corrective emotional experience through our relationship and interaction with them. So what is a corrective emotional experience? Although sometimes we will fall into a countertransference transference enactment trap, a corrective emotional experience is to try not to react to the client the way that they evoke a reaction in many people in their life, a negative reaction. And so I worked with a graduate student, a client once, who had an intake with another therapist first, as was very common in the counseling center. I read over the notes. I shared with the client initially what I learned about them from the notes and gave them an opportunity to correct any of it. You can't write everything in the notes. Within 15 minutes, I asked her a question that apparently the other therapist had asked but not written about. She became enraged at me asking and screamed at me, "Didn't the other person already tell you this information?" Now, if I enacted this with her as a therapist, I would have gotten irritated with her. I would have reacted angrily. I would have said, "Well, what do you want from me? How can I know everything?" The corrective emotional experience was to ask her, "Are you at all aware of feeling somewhat irritated?" In which she was able to calm down, take a step back, and eventually say, I am irritated, but I don't know why. And so the corrective emotional experience is the ability to not enact these relationship patterns. My saying, "Are you at all aware?" was trying to get her to be more cognitive and take a step back and take a look at what was happening between the two of us. Relational patterns look at defenses, or what the interpersonal psychiatrist Harry Stack Sullivan called security operations. You may be familiar, defenses are unconscious. And I think one of the main reasons people defend against things is to preserve their self-esteem, to not be aware of something or to deal with something that they may feel ashamed about, or puts them in a poor light. So when the scholar on TV, Dr. House, says that everybody lies, I think that maybe everybody lies to preserve their self-esteem, not because they're trying to just be not candid. And the unconscious as a motivating factor is part of the relational approach. So before I get into a case, who could benefit from brief, insight-oriented psychotherapy? Well, it's not necessarily related to a diagnosis. People used to try to come up with, well, what diagnoses can benefit from brief therapy, whether it's psychodynamic or cognitive. What we want is somebody who has the ability to have what we call an observing ego, which is really a lingo to say they can take a step back and think about things and reflect on them, like the woman who was able to say, "You know, I'm irritated, but I don't know why." Now, if you've worked with people with severe borderline pathology, it takes a while for that to kick in. And I wouldn't knowingly use a brief approach with them, because people who have severe psychopathology, a mentor of mine taught me that you strike while the iron is cold, that when there's a lot of rage is not the time to try and interpret. Who else may benefit? Some awareness of playing playing a role, or being open to playing a role in their problems with others. This is not something we as human beings easily want to acknowledge, that we are not only the victim of everybody in our life in all circumstances, that we enact relational patterns that don't get our needs met, that put people off, all of this. So you want to see, when you're doing intake and initial, can they have some idea that they play a role in their difficulties? Motivation to deal with painful thoughts and feelings, and an ability to engage and rapidly disengage with the therapist. If they've had significant attachment problems and losses and trauma, you may want to be more cautious about a short-term approach. Now, a lot of you are probably thinking, Well, how do you do that when you work in settings where you generally have a short-term approach? It's not always possible. And then I think you need to talk more about the fact that we'll be working together and the relationship will be ending in a certain part, to keep reminding the client about the termination and feelings that may get activated in it, to titrate sessions towards the end so that you're seeing them every 2 or 3 weeks rather than just ending abruptly. There are ways to kind of change the dosage, so to speak, as you're working with people who might find the ending a little more difficult. Quickly, I want to talk about, I think in every psychotherapy, but I want to talk about in relational therapy, there are both supportive aspects to the therapy and there are expressive aspects to psychotherapy. The supportive aspects include defining the boundaries and the limitations, when we'll meet, how we'll work together. And what I'm really saying here is that all that takes place should be in the service of the client's benefit and increasing their self-understanding. And I'm including self-disclosure in that, because self-disclosure, which can be a whole topic, can be appropriate and therapeutic if it is for the benefit of the client and not because the therapist feels compelled to disclose something. Empathy is certainly a supportive aspect of the psychotherapy in which we want to help the person feel understood and soothed in some way. And I would add that actually what eventually really helps the relationship is what we refer to as accurate empathy. When we finally say something that the person feels, wow, this therapist gets me in some way. They correctly understand something, and that certainly helps the relationship. An example from a session I had yesterday with an adult who's struggling a lot with a oppositional adolescent who the police have had to been called to the home. The adolescent is saying the father is too heavy-handed. The mother has said this. When I came to understand how scared the father is about whether his son will ever be able to function in life, and part of that understanding came from his talking about that there was another sibling in the house, an 18-year-old with severe autism who recognizes them but is nonverbal, and they'll have to take care of her whole life. And when I brought up to him, knowing about your daughter and what's going on with your son, I can really, it gives me a deeper understanding of how panicked you are at whether he's going to function in life someday, because he's not doing his schoolwork and he's not taking care of his diabetes and all of that. And maybe that makes you sometimes a little heavy-handed. And he said, I think you really are getting me now. So I think that's a very important. Preserving the self-esteem by not shaming, not always an easy thing because a lot of clients come in and they feel very badly about themselves. And acknowledging client gains is a supportive aspect of the work. You see this a lot with people, with OCD that I work with who, well, big deal. I now check the lock 15 times instead of 32 times when I leave the house. Well, it is a big deal. And people can be very hard on themselves about their gains. And the preserving self-esteem, part of the way I try to do that is by being mindful of the words and the language that I use. Very careful about the language that I use. So these are important aspects. The expressive or insight aspects of psychotherapy, clarification is a word we use in the psychodynamic lingo, which is really to sharpen and bring issues and emotions into focus. Interpretation, where we try to help the client to have the understanding rather than just, quote, tell them. A genetic interpretation refers to, something about your past and understanding it with more insight. And transference has to do with the interpersonal patterns that you're repeating. And also in a psychodynamic therapy, when we deal with transference, there's the use of self, because we are not just a observer of the psychotherapy, we are a participant observer in the psychotherapy. When I see a client and they tell me certain issues, and when Dr. Zeman sees a client, and some of you see clients, while we may work from the same or similar frameworks, there's going to be a different experience and dynamic and mutual interaction in the room, because I am a participant as well and need to be mindful of my own interpersonal patterns. Okay. So let me get to a case by talking about how I've come to this. In 1984, Dr. Luborsky published a seminal book in psychotherapy research that's called Principles of Psychodynamic Therapy, a Manual for Supportive Expressive Treatment. And not too long after that, or around the same time, and I'm going to talk about him in a few minutes, a friend and colleague of mine, Jeff Binder, worked with another well-known researcher, Hans Strupp from Vanderbilt. Dr. Luborsky was from University of Pennsylvania, and they published Psychotherapy in a New Key and talked about the cyclical maladaptive pattern. So what Dr. Luborsky, who was a psychologist and a psychoanalyst, asked himself as he did psychotherapy research and looked at psychotherapy research was, when people come to therapy, what are they really talking about? What do they bring to the therapist? And what he realized was that people come and they talk about stories. They talk about narratives. They talk about people in the past of their life. They talk about people in their current life. And sometimes, subtly or overtly, they talk about the therapist. And so what he started to do was to look at, and I had the honor of, the ink wasn't dry on my diploma, and a faculty member got me connected with him, and being a research associate, we looked at hundreds and hundreds and hundreds of psychotherapy transcripts, verbatim transcripts that were there from some of the psychodynamic training institutes. And we looked at all of these narratives, which we called relationship episodes, and we looked at them throughout therapy sessions. And we saw that there were recurrent themes that occurred in the narratives when the client discusses people in their life, including the therapist. So we looked at the data and we analyzed the data. And we saw that they also, as I mentioned, talk about their interaction either directly or subtly about the therapist. So it's not always transference, but if a client says to me, for example, I saw my medical doctor last week and he really rushed me, and I don't think he really was paying a lot of attention to what I was saying and really trying to understand me in depth. He or she could just be talking about their medical doctor visit. They also could possibly be talking about some of their visits with me. I need to listen carefully and see if there is a possible transference element. Sometimes it's much more direct than that. But part of what he was looking at was, what are they talking about in these stories? Not just that they're telling the stories, but what are the themes and what's the data of these stories? And to show how the interpersonal scenarios and the interactions, what they really mean and how they relate to symptoms, okay? Oh, actually, before I move from that quickly, you know, a funny story was when I was a practicum student ages ago, I worked with adolescents in a day treatment facility, and several of the practicum students and I were having lunch at a place near there. One of my clients walks in, and I really didn't want to interact with him because of lots of reasons right then, and it wouldn't be appropriate for him to get into stuff with me. So you know, to be honest, I pretended not to see him. I see him in the next session, and he starts the session by saying to me, you know, and he's referring to the temperature, it feels rather cold in here. And being psychodynamic, I'm convinced, oh my God, he saw me, he realized I gave him the cold shoulder, and now this is coming up. And, you know, maybe in a dozen ways I hounded him, you know, does this bring anything else to mind? No, 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 no. Maybe he was just saying it was cold in there and I felt guilty. Maybe there was a conscious or unconscious thing there, but it's hard to know. So you really need to be listening for these kinds of things. So what did Dr. Luborsky look at in all of these sessions? So what he did was he looked at what are the components of the predominant themes, which he called the CCRT, or Core Conflictual Relationship Theme. And if you look at hundreds of transcripts of the same client, you'll see that in these different scenarios with people in their life, they will express several wishes, needs, or intentions. What do they want from other people in their life? Some of it may be very, very directly stated. Some of it may be a little implied or subtle. And these are just a couple of examples of the many interpersonal wishes a person can say, can show, you know, the wish to be valued, the wish to be understood, the wish not to be obligated to submit to the will of other people. And there are dozens and dozens of things people need or want from one another. And what we looked at over many, many sessions was, are there one or two predominant wishes that really are there throughout the psychotherapy? And that would be the main wish, need, or intention. The other thing he looked at was, well, how does the other person respond to this wish? And it can be actual or expected. Doesn't value me, misunderstands me, dominates me. And the expected response from the other certainly may have a transference aspect to it. I expect that faculty member to be critical and disappointed in my work. I expected Dr. Friedman to have given my appointment away. So what we're looking at is the response from other, actual or expected, but sometimes the expected response may be a transference aspect. I didn't ask that person out because I knew how they would respond to me. And we're also keeping in mind the client's unintentional role in having their needs unmet, because they're repeating maladaptive patterns from growing up. You know, so I worked with a guy who really wanted his wife to value him and to see him as trying to support her growth and development. And he was an expert on something I'm not an expert on, crossword puzzles. And she said, you know, maybe I'll try crossword puzzle. Would you go to the store and get me a beginner one? He said, sure. So he goes to the store and he's looking at the beginner ones and thinking, no, that's too easy. She's too bright. So he gets her a really advanced crossword puzzle, brings it home with great pride. And she says, great, you want me to look stupid. And that's why you bought that for me, because you know I don't know how to do them as well as you. He certainly unintendedly sabotaged his wish to be seen as supporting her growth and valuing her by his action. Does he do that with other people in life? Maybe. The last component then would be, well, how does the client respond to whether their need is met or not? And what Dr. Luborsky and many interpersonal psychodynamic folks say is that the symptom, such as depression, anxiety, anger, self-defeating behaviors, alienating others, repeating maladaptive patterns, the symptom is viewed through a relational perspective. The symptom comes from not having the wish met and the maladaptive pattern that gets repeated with others, as opposed to the symptom falling out of the sky. Now, I'm not saying that, depression, anxiety are never biologically related, but from the view of psychotherapy, this perspective looks at symptoms as related to this maladaptive interpersonal pattern. Okay. So these are some of the core things. So we look at the most frequent wish, need, or intention, the response from other, actual or expected, some transference component, how the client responds in terms of their symptoms and their maladaptive patterns. And so let's say one or two wishes seem to be predominant. So which one do we really explore? So my friend Dr. Binder gives us some guidance. The narrative theme that we explore is the one represented by the pattern that provides a plausible and meaningful explanation of the patient's symptom and other problems. This pattern recurs frequently and with noticeable intensity in many relationships in the person's life. The pattern is part of what appears to be a dysfunctional style that contributes to interpersonal difficulties, often including the therapist, and leaves the patient feeling anxious, depressed, and unfulfilled. And the interpersonal pattern represents a plausible, meaningful, heuristically useful facet of the patient's life story. So we're looking at interpersonal themes and patterns. Okay.
Dr. Friedman, that's about 32 minutes.
Okay, let me quickly tell you about a case, and then I'll end up and take some questions. So I worked with a college student many years ago who came in and said, I'm here, Dr. Friedman, because my fiance told me to come here. I understand I am being incredibly irritable, and he can't even load the refrigerator correctly. And I value that relationship, but everything he does is wrong to me. I'm angry. I don't make friends. I am doing well in all my literature courses as a literature major, but I'm failing one course. I'm miserable, I'm depressed, and I'm enraged all the time. When I get her history, I learn within the first session that her father was an incredibly successful person in accounting and business. Her mother was a nurse who had her own career as a nurse and then gave up nursing to raise her and her brother, who were several years older than her. Her brother was in the father's footsteps and studying business and accounting and doing very well in it. Her fiance was in law school, and while she was proud of him, he had just recently earned an honor in law school. She was in a master's program because she deferred getting into a doctorate program that she got into so they could be in the same school where he got into law school. So it started to give me a picture of a young woman who, although very bright, felt that her literature career was never valued by her father, who wanted her to go into business and accounting like her brother did. Her mother valued her tremendously, but she didn't take great solace in that because she valued her father and his business career more than the mother's nursing and quote, giving up her career to raise children. She gave up a doctoral degree temporarily for the boyfriend. After he made this honor, while she appreciated and valued it, she started to become depressed because she was not getting those accolades. I found out that the class she was failing was because she was angry and wasn't doing the work, because the well-known literature professor who was, quote, teaching the course came occasionally and left the course to be taught by a graduate student. And her attitude was, if he doesn't value me, I'm not going to do the work, the hell with him, as if as if he personally would know this and say, oh my God, so-and-so isn't doing their work. I learned that her parents went to lots of social events that the father had as a successful business person, and she was often left in the care of her 2-year older brother, who she didn't feel had the right to order her around the way she didn't feel the graduate student had a right to teach her in the course because she was brighter than the graduate student. And it goes on and on in terms of the theme of not feeling particularly valued, and why don't you have any friends? Well, it's only a master's program. They're not as bright as me. I got into a doctoral program, even though this is a prestigious master's program, and I guarantee you that there were many bright people in that program, but she couldn't allow herself to see it that way. So you can see that the wish that she's expressing is to be valued, to be taken seriously. And although the fiance does, his making this honor has really caused conflict between the two of them. The response from other that she feels, her dad, the professor, some other people in her life that she projects this onto, don't value me, don't think I'm worthwhile. Her response of self is, I'm angry, I'm critical, I'm irritable, I do self-defeating things like fail a course. I'm ruining my relationship, although I value it tremendously. So you can see that what I'm trying to do here is to help make this pattern conscious for her so that we can eventually work it through and see how it happens with others in her life too, and all of this. And so this is the thing that I want to say to her. So what do I say to her? And then I'll see if there are questions. At the end of the first session, after learning all of this and hearing her family history and understanding at least this is a hypothetical relational pattern, I say to her, if it's okay, let me give you a hypothesis here. I discuss, the wish to feel valued, a little bit about her childhood, how she's seeing others, realistically, but also through the lens of this distorted template, how the symptoms are there interpersonally. And because of her self-esteem, I felt the need. I said to her, you're a really bright young woman, and I think we can work together on this pattern, 16 to 18 sessions, and it can be tremendously helpful to you. And she looked at me and said, are you being sarcastic? And I said to her, well, that's fascinating. And she said, well, what's so fascinating? And I was able to help her see that the pattern just became activated and alive in the room between the two of us. Because my saying as an authority figure, as a male, as somebody with a doctorate, you're a very bright young woman, I could only be saying this derisively and sarcastically. And so pointing out, and this doesn't always happen, that the theme became activated further helped her to see I'm on board. let's see if we can work this out, because I've pushed away everybody. I'm pushing away my fiance, and I just told you that you are a lying, horrible person for telling me I'm a bright young woman when you don't really feel I am. And then I have some references to share with you. And so let me open this up if there are any questions.
Well, thank you, Dr. Friedman, for that very informative and interesting presentation. I'll let you know that one of the things that I'm taking away is strike when the iron is cold. Like, wow, what a metaphor to take away. So we do have some questions, and I'm going to start with a pragmatic one. Attendees are interested in knowing if you will be able to share the slides.
Yes, I gave the slides to events, to Carly in
Okay.
events, and
Yeah.
also the recording. And she also told me, which I don't know exactly how this will happen, that it will be on YouTube as well.
Yeah, we're in the process apparently of creating an e-archive. So it's in development. They are recorded, they are saved, and they're not yet accessible. Yes, Carly did let me know that about the slides. I just wasn't sure where, so I'll get that information from Carly. So let's go to the first question. And this is from Sarah Posh. Do you also think that people become defensive because it touches on a soft spot where they don't want to delve into anything deeper? If yes, how would you approach this?
Yes, certainly. I think that, as I mentioned earlier, when things hit self-esteem, um, so um, an example was years ago when I was in a practicum, and we had this thing that you can see in a museum called a tape recorder, and um, Don and I know what a tape recorder is. So when I would tape clients in my practicum, and one of the clients talking about his family and his friend's family said, when I go on vacation with my friend's family, I have a better time than with my parents. And I said, well, how so? How do you have a better time? And he said, I didn't say better, I said different, because he couldn't allow himself to, quote, criticize his parents. And he said, play that back. And I said, well, I could, but I think I know what it's going to say. So let's take a look at how you've come to the idea, perhaps, that it is taboo or makes you a bad person to say something other than just very favorable about one's family. So I try and get them to explore that issue. But your question raises a very important thing that I want to stress, which has to do with not attacking the client with something they're defending against directly. So if we're working with somebody and we've learned that anger in their family was a very taboo thing, and if we tell them, wow, you seem to be really enraged at your mother, they're going to hear that as our calling them a bad person. So what I might say is, in spite of the way you say your mom is treating you, you're working incredibly hard to be pleasant. I've laid out both sides of the ambivalence, and then I see which side they take and how they respond. So I haven't accused them of something. So it's a good question. When people are defending against something, we need to be careful not to try to accuse them of the thing they're defending against.
Thanks, Dr. Friedman. Giovanna Barreto has given us a clinical question. Once had a client, she was 40 years old and she lost her only daughter by suicide. The interesting thing was that her transference towards me was shocking because she thought that her daughter was communicating with her through me. How would you manage this kind of transference?
Yeah. Yeah. I mean, in that tragic thing, what I try to do, and obviously you have to take the client's state of mind into account. Is there a psychosis? Is there just a strong wish? Um, I'll give you an example of what I might say. And I said this to a client with schizophrenia that I saw in a practicum, who had denied that his father was gone, even though he had been gone for a number of years. And in one session, he said to me, something terrible happened. And I thought he meant like, that day. And he said, my father passed away. And then the psychotic denial kicked in. And 2 seconds later, he looked at me and said, I loved you as a child and I love you now. I became the dad. And so I looked at him and said, it is really an honor that you could see me that way. So I didn't agree, just I said that way, to help him see, to get through that that's not correct, but that you're putting these characteristics on me. And I might say, with such a tragic loss, I can only imagine, and I feel an honor that you could see me in that way, although you know that I'm the therapist working with you, and see how that works.
Great. Well, thank you very much, Dr. Friedman. This question is from Sakline Bhatia. Would this therapy benefit in addictions-related cases in family dynamics? That is, addicts and or their spouses. If yes, please elaborate.
Yeah, very good question. I haven't worked with it as much, but Dr. Luborsky and another doctor, last name is Woody, W-O-O-D-Y, there's a literature out there of the use of the CCRT with substance abusers, including cocaine. And so there is a literature out there in terms of, because one of the ways, I mean, I'm not an addiction expert, but you certainly hear people say, I did this because of you and because of that interaction. And so it tries to help people with addiction look at their role in the maladaptive patterns, and that the substance use is another symptom of a maladaptive pattern and the needs not being met. And the interesting thing I want to say too is, look, as the Rolling Stones said, you can't always get what you want. So not all our needs are going to be met by everybody. And we don't want to imply that with our clients. But when you look at successful psychotherapies over all these transcripts we looked at, the wish rarely changes. What changes is how the person interacts with others and the response from other, in terms of more mature ways of seeking to have our needs met and changing our maladaptive patterns. But look at the literature on it, because this method is used a lot in the substance abuse treatment.
Great, thank you very much. From Anna Sigalchik, how would you recommend we handle our own emotions when with a client, for example, wanting to cry?
I think that while we don't want to, quote, burden the client, there are times when things touch us in a way where we have a genuine emotion. And I think then that's something that gets discussed. Now, people are going to have different opinions about this. I try to not, let my emotions leak out all the time, but I have been, in the many years, I've been told things that are horrific. And I am the kind of therapist who will sometimes, if I'm genuinely feeling that, will say to the person, how horrible, when I hear certain things, and they'll react to that. Sometimes people will try, no, it's okay, try to reassure me, although they just talked about, horrible loss. But yeah, I mean, there are times where we are very touched by things. What I think we need to do then, in terms of countertransference, is not to over-identify and lose what they're saying, because we've now put ourselves into the situation, and it makes it harder to see them or assume that they're having the same experience we are.
Well, thank you. The next question is from Brandon Iaforti, and wonders if you could touch on the benefits of forgiveness practice for helping clients.
Yeah, it's not exactly directed to this, but it is in some ways. Forgiveness means different things to different people. And so I'm always curious about what forgiveness means to them. And that forgiving doesn't necessarily mean, certainly condoning. But in terms of wishes not being met or neglectful or abusive parents, for example, I certainly want to see what my clients feel about how that gets part of their story and what they tell themselves. Because certainly sometimes there are people in their lives saying, well, that's your mother or father. If you don't forgive them, you're not a good person. So I really want to be open to all of the facets about what they think is forgiveness, what that means to them, and what they're being told by others. When people are abused and they blame themselves at times for the abuse, I certainly have said to some clients, there's no such thing as a bad infant. But yeah, forgiveness is, it's a tough topic because it means different things to different people. And sometimes forgiveness for some clients I found means not allowing this to have the same impact it's had on me. So it's a very unique to the client situation.
Thank you, Dr. Friedman. When that question came up, I was thinking of Kernberg and psychodynamics. So that maybe somebody, you can go look up Kernberg and psychodynamic practices and forgiveness to Brandon. This question is from Marcy Intwiga. Are you aware of work with caregivers in distress? Goodness, rented lips this morning. Are you aware of any work with caregivers in distress using this approach?
No, it's a great question, but I can see its applicability because for both the caregiver and the person who's being taken care of in terms of the wishes, needs, intents, and the response, the transference, the multitude of mixed emotions that can come into play when one is charged with taking care of somebody, particularly if there's been a great deal of ambivalence in that relationship to start with, where here you are and you now have to take care of somebody who you feel hasn't treated you well your whole life. So it's a great question. An area that this hasn't been done as much with, that I and a colleague are going to look at, but then COVID hit, so we're going to wait till we can see people can be seen in the office, is applying it to, which I've done before, but haven't researched, to couples psychotherapy.
Oh, thank you. This question is another pragmatic one, and it may be answered by way of, you have references at the end of the slide. Dale Petty was wondering if you have additional resources, books, websites that you recommend.
Yes, there are references, and also if anybody wants to email me at sfriedman, Friedman, at yorkvilleu.ca, I'll be glad to share things. And there's also a lot of stuff on YouTube as well. So yes, I'll be glad to do that.
Great, thank you. From Karen Jones, if a client starts with the attitude, as you alluded to earlier, that they do not want to dive too deeply or dwell on the past, how can you define boundaries around how far back and how deep you will explore?
Yeah.
There's several other questions. Maybe start there.
Yeah, no, it's a good question. And I have people who say to me, look, this is what we're going to do. I discuss with them what their view of the past is and discussing it. But I do say to them, again, we probably will find, and hopefully you'll be curious about this, that some of your interactions with people have some residual relationship to it. And if we find that, let's talk about whether that happens in other relationships. So then eventually, as they're talking about people in their life, we learn, and I ask them, this pattern that just occurred, is this familiar to you? And some of them are, oh, yeah. And they'll tell me about it from past relationships, or in my family, I was never allowed to have my own voice. So I don't take the arm wrestling approach, but I do try to show them that if we see things, then let's be open to what they might mean.
Good. Well, thank you. Maybe we'll just have time for maybe two more questions. From Farah Fatima. I'm wondering if you already have had a few sessions with the client, can you bring in relational therapy in the next sessions?
Yes, I think regardless of your orientation, you can always say to somebody, as we're talking, it strikes me that the relationships and the patterns seem to be very important. Does that make sense to you? And maybe give an example of that and see if that resonates with them. It's not that CBT therapists don't talk about interactions with people. They may talk about them similarly, they may talk about them differently. Aaron Beck, who had psychodynamic training, discusses that if you're working with personality disorders, particularly borderline, and you don't know how to recognize and manage transference, good luck. Because as he put it, they live at that level. So.
No, thank you. From Joanne Matt, and this will probably have to be the final question because we're nearing the end of the time. She thanks you for the presentation. Joanne says that she is a healthcare provider in Ontario. There are many mental health care programs offering brief counseling that are covered by the provincial healthcare plan, limited to 6 to 8 sessions. In Joanne's experience, referrals are waitlisted for months. The programs all seem to be based on CBT. So Joanne's wondering if you're familiar with this type of very brief mental health counseling and any comment on effectiveness or who might suit this type of program for future referrals.
Yeah, it's a good question. I think as long as you are, when I see clients, I talk about short-term goals and long-term goals. We're not necessarily going to create, quote, personality change here in a short-term approach, but I think it's appropriate for people who have symptoms and maybe a very focal problem in terms of relating to others, and you're able to quickly highlight this pattern with them, and they're open to discussing it. And so I think in 6 or 8 sessions, you can at least get them to become more aware of a pattern that they might become more mindful about. When I interact with others, this is what I tend to bring to it. And boy, this isn't really getting my needs met. So I do think it's applicable as long as you're measured about what you hope to accomplish.
Great. Well, thank you very much. We're right near the end of the time. Dr. Friedman, thank you for this really enlightening presentation on brief psychodynamic therapy, a relational approach. Great presentation, and thank you for answering all of those excellent questions. There are certainly additional questions, and that's just let you know how interesting everyone found it and how you've sparked further thinking in this area. So I want to thank you, and I hope that you all have a wonderful day.
Well, thank you so much, and please feel free to email me any questions, and I appreciate folks attending. Take care, everybody.
Bye for now.